Hello, everyone, and welcome to part two of the intake process podcast. It's an unfiltered podcast, so expect to hear some pretty obvious, pretty blunt statements to be made about your intake process. And I promised that I would bring Cindy Craft to this one because she is the process master at K&K. And these two ladies that are with me are also process masters. I am not. I am like your marketer that has to go out and be the face of your company and offer all the information about your company so that you can get that business. But I'm not the one you want checking your paperwork. I am not the detail-oriented person. It's not in my personality makeup. And very rarely do you see the person that can go out and speak in social environments and have, make people feel good about themselves so that they're going to send you business. Very rarely do you see that in combination with a very detailed, complex, loving that detail type of personality. So please bear with us as we walk this through because we want to give you a process that's going to work. Gone are the days, and Cindy's going to smile and nod here, gone are the days of receiving a name and a location and having to go out and bird dog that referral, right, Cindy? And go out and not know what's going on in that house before you walk in.
Oh, I remember when you got a name and the address, a good portion of the time was incorrect, or the phone number wasn't right. So you basically had nothing other than trying to track them down and find out where they are. Clinical information was, it was either feast or famine. You would also get referrals that had every piece of paper known to man. And it's like, okay, realistically, I'm not going to read all of that either.
And when we got the EMRs, a lot of that stuff was able to be checked behind the scenes, and a lot of that stuff became more accurate. But then what happened what had happened was that people started inputting information and stuff. It was like Swiss cheese. There was a lot of really good stuff, but then there were holes all over the place in that documentation. And as we talked about in the last podcast, those holes cause delay. And anytime you have delay, it's difficult, especially when you're on such a tight frame to make sure that you're getting paid as soon as you possibly can in home health. It's really important that you get this information up front. So I tasked everyone with coming with what they thought would be a great intake process. And so I'm going to start. I am hosting a lunch at a physician's office. I've got everybody in the office. I've taken their orders. I went and got some special food, maybe vegetarian menu, maybe they wanted Indian that day. And I'm going to educate them on the face-to-face process. So I've gotten that face-to-face. I know the face-to-face process. I haven't really ever dealt with having what it does to the chart, but I know I have to discuss that with them when I'm in that office. And when I'm in that office, they hand me the name and the information, the demographic information on two patients. Now what? Cindy, do you want to kick us off?
Well, I think my contribution is going to be different in this because I'm not a coder. And I think part of the issue when you look at intake and recommendations about how to handle intake, we also have to recognize that we have created essentially the proverbial silos. Intake's on an island, the clinician's on an island, the coder's on an island. We put you all on an island because you should be on an island. I'm sorry. I have great appreciation for that skill set. But I think what happens in any conversation, the minute we reference it to coding, there's a knee-jerk reaction from everyone else to say, that's a coder. That's a coder. Hands off. That's a coding issue. And coders should be the one to deal with the coding issue. I think we need to change the script a little bit and say, this is about managing the patient. How are we managing the patient from the time you gave them their Indian food and got that referral till the clinician is going out there and doing a comprehensive assessment of the patient? Because that whole thing is one continuous process where coding has multiple opportunities for touching it in between. And I think part of the challenge we've had in developing a process is we tend to make an intake process, and we make a clinician process, and we make a coding process. And then the three don't work together very well. And then I think when we run into issues or delays, and I know you guys talked a lot about delays and things in part one, but how well does intake understand that missing pieces of information, how much rework is actually occurring? Not in a punitive, it's your fault. Nobody's saying that this is intake's fault, but you're the entry point. So things that happen downstream, do we periodically regroup as a team and look at what's working, what isn't? I may in intake say, I got my 2 referrals today. Man, I'm good. I've met my target. Here, I gave it back to the agency, and I'm going back to the next doctor's office to get 2 more, unaware that some of the things I may have missed unintentionally have caused a problem down here. Or it gets to the clinician who goes in there and goes, oh, yeah, that face-to-face primary reason doesn't really look right, but the coder will fix that. And then the focus of care is, yeah, whatever, the primary diagnosis, I'll put that there because that's just all coding issues. And I'm going to go do my clinical stuff. As all three have heard me say numerous times, I don't understand as an outsourced provider how the coder this far down the line is the one going, time out. We don't have what we need.
Hmm?
How did we get there? So our tips today are to look at that holistic thing. No one is saying intake is the problem. No one is saying the coder is the problem. No one's saying the clinician's the problem. But they don't seem to be on the same page as often as they should be. And if you're watching this going, ours works great. We don't have any problems. We have this fabulous document and we do all this. You have not wasted your time today. Consider yourself validated that you actually have a handle on it. If you think you have a handle, but you're not sure, going into all these coding changes, ugh, you guys freak me out every time you talk about it. Coding changes October 1 would be a great window to say, maybe we should dust that process off and make sure that we haven't rounded some corners, that sometimes I don't get that piece of information, or sometimes I don't really check that because I'm trying to expedite it. It's a good time to go back and say, if I have a process start to finish, let's just revisit it. And maybe with input from those three parties, I can make some adjustments that make the process better. Because we all know here at K&K, we can sit down and brainstorm one heck of a process. But you got to go back and revisit it periodically because there can be better ways. There can be steps that we thought were great that need to go. There can be things we didn't think about that, wait a minute, we forgot that part, need to be added. So that's my non-coder contribution, is to really look at that big picture and then say, because what I don't want folks to, I'm going to say it again, I just don't want folks to think K&K came out with a 2-part bashing of intake. That's not the intent here. We just see in talking with Kelly and Jackie and what they do day in, day out, that it reaching the level of the coder with these kinds of things missing, there has to be a better way than multiple emails, than the clinical manager having to track down a piece of documentation and frustrated that the doctor who referred this 2 weeks ago doesn't want to send you that information because they thought they were already done with it. And all of this back and forth. Is there a way we could do something at the beginning to try to minimize it? We can't eliminate it. There's always going to be that problem doctor who doesn't want to return your phone calls and won't send you anything. But that should really not be the norm. And sometimes, you know this, Jackie and Kelly, what we hear, it sounds like it's the norm. And it seems like there's got to be a better way to do this.
And obviously, everybody can know why Sydney was brought to this call today was exactly that. I think that it's not only going to improve the process to your coder, but it also is going to improve you in reverse to the clinician. And the clinician's going to go out there armed with the absolute most information that they can have to take the best care of that patient. So, Jackie and Kelly, I've given you all the money in the world and you can create an intake process. So beyond that, I know neither one of you have it in your mind that you think it's an enjoyable experience to go give a lunch and a chat to a bunch of doctors that don't want to listen
Oh, no.
and do the dog and pony show, and do the people thing. And I know that some people are peoply and some people are not peoply. Your marketing folks are peoply. They're people, and they want to go out and see more people to get more referrals and more leads for you. So who wants to start? Jackie or Kelly? Go ahead and start. What does that look like once that information, the demographic information, has been gathered by the people person?
I'll let Kelly start so that I don't monopolize.
Right. Let's see. How do I want to interpret all this? The coder in me really wants you to get that, that diagnosis right from the beginning. We want to ask those questions. That's just me. Because when I see a chart, the first thing I look for, I want to see my face-to-face is there, is my diagnosis that's driving the home care there. That's my important thing for me. So I know we've discussed before about, having some type of process, like Cindy said, having everyone collaborate together, somehow getting everybody together. Maybe that is some sort of a of a meeting with your team, like to collaborate all of that together. Maybe that's some sort of checklist altogether. And going back, like Cindy said, checking through the process of intake and making sure everyone collaborates to get that information.
So you're
Um,
saying collaborate and create a list of items that need to be gathered at that initial contact with the referral. And Jackie, is that something that you can see a marketing type personality being able to do well?
No, not necessarily. You can create a cheat sheet, a simple cheat sheet on things to look out for. And that if you don't see it in the packet that's being handled to you, a referral pack is being handed to you saying, skilled nurse evaluate and treat. Okay, so that's okay, what for? That's a simple one. Or they're giving a symptom code and not a disease process. Knowing that, oh, it's a surgery patient, it's a joint replacement. I need an op report to go with this packet. There are certain key things, and the biggest one, wounds. Refer to skilled nursing for wound care. Left leg. Need etiology and severity. Location, etiology, severity. There's certain things on that checklist that are the biggest abusers that we could help the intake out with. But I'm going to take it a step further and say, after you develop that checklist with the coder's input, you won't be able to take all the coder's advice because they'll give you 10 pages worth of stuff, identifying your homebound status, the physician encounter, the face-to-face the physician attestation, making sure dates line up, things. My suggestion beyond that is to have somebody like me, which is basically a document specialist, somebody that can handle the logistics of, did I get what we need from the intake person? Are all the pages, did the physician sign it? Is it from the right time frame? Is it from the right facility? Does it have the primary diagnosis listed? What are we missing in these documents that the intake person may have missed? Because even with the best checklist, they're going to miss some.
Mm-hmm.
If you had a document specialist that does not even need to be clinical, that person can work closely with the coders and get everything in line as to what they need to be looking for.
And I'll take that one step further. They can work closely with the marketing staff, and they can be that liaison with the marketing staff to maybe go along with them to said lunch and help with the logistics of it. And then when you get that referral, they go and gather the information that minute from that patient's chart in the office that you're in. Let the marketer go out and do their marketing things. Let them go out to their next public facing situation. Let the clerical or the clerk. This is the level job we're talking about, right, Jackie? We're not talking about a $25, $30 an hour employee. We're talking about
it's basically like your hospital X-ray file room clerk.
Boom.
That is basically what you're looking for. Somebody that gathers the documents, make sure they have all the documents, and that they make it where they need to make it.
Well, and in our partner agencies, correct me if I'm wrong, Jackie and Kelly, some of the strongest ones at doing that are not clinical.
Mm-hmm.
Correct.
Because I think clinical sometimes gets lost in the weeds or kind of gets off track, as opposed to someone that is focused on, this is the checklist, this is what needs to be here. If it's missing, this is what we're going to have to do to get it. I think a lot of times there's a lot of intention around that, or we assign that role as part of somebody who's wearing multiple hats, and it can get lost in the shuffle, or we start thinking it has to be a clinician, because if you're going to, find it and the wound information isn't complete, well, then you can't really call the doctor and get new orders. Correct. But that gatekeeper can help us identify it consistently. They don't get pulled into visits. They don't get pulled into who had a leaky catheter case conference. They don't get pulled into that. So they're able to really give it that focus with an eye toward keeping it consistent. But I think part of the challenge has been people will ask me, what is a complete referral? What defines a complete referral? Well, they go to CMS and CMS doesn't really say. And that can be both a blessing and a curse. If it's too specific, we tend to buck and say, this is ridiculous, you missed this, or it's overkill. But when it's gray, then we end up kind of piecing it together. We know we need to have the face-to-face information. We know there's some things we need, but the full scope of those documents are not really, they don't say you have to have, you know, an H&P with this in this time frame. You don't, and that's why I think back in the old days, we'd get records, you know, I'm glad, and it was bad because they were photocopying. This wasn't even electronic. They're slaughtering all the trees, giving me op reports from a year ago. I don't want that. No, don't care. But I think that it's without a clear definition, it allows some of that rounding of the corner. Someone reached out to me recently, very frustrated that their agency is basically reverting back to name and an address, and we'll just get the face-to-face. We'll get all of that later. Is that compliant? There's nothing I can find that says it's not compliant in the technical sense. So I think that's where, when we look at it and say, is there somewhere I can go? Where is the definitive list of what should be a referral? CMS has said, you define complete, but they've empowered us to say, you do not need to move on that referral until it is complete.
Mm-hmm.
So I'm not saying it's an ideal situation, but I've had a family member who was referred to a home health agency. The agency was unable to reach the referring physician to get clarifying information and would not admit her till they got it. Now, my beef was, you should tell the family this is what's going on and not just leave them hanging and not tell them while you chase it down. But they had adopted a hard line that until we have X, Y, and Z, we are not going to do that referral. Others will say, oh my gosh, you got to be kidding me. That's a business opportunity. I won't be that hard line. I'll take all those patients and admit them right away. You're technically okay, but then how much back work have you caused because you took it? Now they're yours. Now the doctor who won't sign something or won't give you something, you're already in it.
And Cindy, I was going to say, the minute we set a clerical position to assist with the marketing and with the coding requirements, people shut their heads off. We can't hire anybody. We can't hire any support staff. We can't afford it. Well, guess what? You're affording it and then some now.
On the back end.
On the back end. The amount of delays that occur as a result of this paperwork not being where it should be is costing you on the back end. It's costing you in a delay in being able to bill. It's costing you on billing and coding the right information. And I'm not talking about, this is not to me an office position. It probably will be in the office some, but I see this person with a clinical type laptop or iPad or a phone even that is secure. And when they have to get information out of a chart, they're literally taking pictures or scanning it on their phone directly into the medical record. So you're eliminating the step of receiving the paper and then scanning it into the system, lock, stock, and barrel, because they don't know what they're looking for. So they're putting everything into the system. And you're having a person that knows exactly what they're looking for. And here's the thing I want to say. There are people who really like this job. That's hard for me to understand because this is not in my wheelhouse. But there are people that really like this job. And I might be, Jackie just put her hand up. I might
That's
be
why we
talking
have
to
Jackie
people.
and Kelly, because
Yeah.
it would not work any other way.
So finding those people is a specific ask, right? So you have to ask, are you a person that likes to follow a list, a checklist? Do you like to go in and get specific on things that are provided to you? Or are you one of those people that wants to people? You want to go out and meet folks and explain to them the virtues of your home health. Delineate out those personality types and be smart about it when you're hiring. So Jackie, what is it that you and your personality type like about those kinds of processes?
It's just detail oriented. I mean, no better, no day is the same.
Mm-hmm.
every day I'm going after the same thing, but it's always a different situation. But I wanted to piggyback on what you were saying about the back end and on the front end. If if an agency is really good at getting the intake and the document specialist going and coordinating with the coders, the amount of time that it frees up that QA, those top line skilled nurses that are supposed to be doing educating or plans of cares or working with clinicians to help get there. The amount of time that gets freed up for them because they're typically the ones that are having to run back and get it once it's already made it all the way down the line to the coders. So you won't be able to eliminate all of the issues, but you can decrease the frequency of the coder having to come back and ask for something that was missed by having more eyes on it from the front end that are trained to look for it.
So my question is, given that wounds, I know from both you and Kelly, Jackie, that seems to be the big sticking point of not getting the right information. Then you reach out and they say, well, the nurse says it's a pressure ulcer. We're not trying to be mean to the nurse. The nurse, we got to have physician documents. And then looking at the number of changes October 1 that are wound related, making things way more specific.
That's where the etiology and the location and severity are definitely going to be key.
So if that's already been a weak area in an organization, if you had to boil it down to an opportunity to either revisit your current process or potentially tweak it, Kelly, would you say going after wounds? And what is if a patient has a wound, what kind of referral information? Because as the non-coder, I look at, it's like, I get the concept that they're making all of these more specific wounds because they do data analysis, and technically coding was never supposed to be about reimbursement. It's supposed to be about tracking and all that. It makes sense. But then I look at it and say, my gosh, if you need that level of detail, and right now I've got wound on left leg, what would you suggest? I mean, would you suggest that's what you go
and
after
most commonly,
first?
a lot of times,
to me, the coders have to learn this anyway. So you can make it a good collaborative. How about the coders without dragging people down the rabbit hole? Because then make our eyes go cross and we stop listening. But could you give us an overview at the agency level? Could the coders come in and talk to the intake people about these new codes and why you're asking for what you're asking for? It's not that a coder is lazy and doesn't want to look it up. I can't look it up if you don't have it.
and I want to interject, hang on, I want to interject real quick here because this clerical position, a lot of times, if you're at a primary care physician, for example, they'll say they have a wound and you ask, well, what kind of wound? And they go, we don't know, they're going to a wound care clinic, right? That's
ding, ding, ding.
ding, ding, ding. Yep. The clerk would pick up and go, okay, I need to make a trip to the wound care clinic, or I got to contact the wound care clinic. I'm going to go there and gather more information about this wound initially, right out the gate. Most oftentimes, as a home health provider, you find out that they're going to the wound care clinic when you try to schedule them. And they tell you they can't be there because they have to go to the wound care clinic. Right? I mean, that's a great example of another function that clerical position could do.
Or coming out of the hospital with wound care orders. Okay, you can get the wound nurse documents from the chart that the hospital record has, because that will give you specific locations, measurements, etiology, the whole 9 yards that the physician's already signed off on.
Right.
But I got a question for you, Kelly. So if we can't get the information now on wounds very well, and there's going to be these new codes effective October 1, what does your gut tell you is going to be the situation October 1 in terms of the physician using these appropriate codes or providing the detail to support that kind of code? Because I'm the non-coder. It could just be, this is just going to be more of a semantic, based on how they described it. I can fairly easily, as long as the document's signed, as a coder, I could find it. Or is there going to be an element of they got to do it too? And we may run into some issues of, despite we got the right information, the detail's still not there. I'm just curious
Yeah.
what you think as a coder.
Yeah, I think the detail won't be there. And until they, all the codes start flowing through other coders and in the systems, like, I'm talking healthcare systems, hospital, until they're asking the doctor for that documentation as well. I mean, we're going to
I
have to have.
think what was it, about 6 to 9 months before we started seeing the physician changes from the last one last October.
Yeah.
So there is
Yeah.
going to be a learning curve. So I think, it's still a good time to look at your process, maybe take wounds as your first attempt to try to mitigate that, but also just be honest that there's going to be a learning curve to this. And there may be some friction back and forth of asking for documentation, and the person who was doing really great at intake is now like, I'm trying to get it, but I can't get it because they're not even writing it that way. We're all in this together. It could just be bumpy for a period of time. And I just wanted to bring that out as a non-coder, because that's where my brain goes is, I understand what we're saying from a process standpoint, but if I can't get if the doctors aren't using the right information, then I don't have it. And that could make it a bit more frustrating, and just be prepared.
And as we're getting a little bit long in the tooth, I wanted to give everybody an opportunity for your last thoughts on what a good process would include. Because I don't think we fully did it today, but I think we've given folks a way to get started in improving their process. Jackie, do you have any final thoughts?
No, it basically starts with collaboration
Mhm.
with all the parties involved. Intake, possibly a document specialist, the QA department, and the coders.
Yep.
To identify where the major areas are, where the hang up is, what's costing people to spend too much of their time on. And you figure out where those bumps are, then you can start with simple changes to refine the process.
What about you, Kelly? Any final thoughts?
I'll kind of piggyback on her too, on what Jackie just said too, with also education to not only clinicians and physicians, but to everyone involved, letting them know, what all they need to maybe to ask the questions, to continue the questions, I guess is what I'm saying. And not to be forceful, with your referral source or whatever, but really being able to dive in and say, yeah, that's good information, but I still need this.
Yes.
I still
Yes.
need more. And to not be afraid to dive in to ask that, because it comes down to your bottom line of needing that.
And as a marketer type personality, I can tell you that it's a whole lot easier to know what I need to prepare somebody for that when I'm selling them something. When I'm selling the agency, if I already let them know that I have a need of this kind of documentation, it's a real way to have your referral source trust you, that you're actually opening up and telling everything that you need. And when they tell you agency B will take it without any of that information, then that's one of those things where you have to decide what your principles and policies are going to be in your agency and how hard you're going to stand up for them. Cindy, thank you again for coming to this podcast, to part 2.
One more thought though on what you just said. I think it would very much help your marketing / intake folks to script the situation.
Yes.
Of what to say when they say, but the other agency doesn't want it. I think if we go, but Medicare requires it, it's a rules thing. They're not following the rules. That just doesn't play well. I think it really is the truth, which is we need this level of detail to provide the appropriate level of care for your patient. And we're not in a facility. We're doing this in their home. So we need the context information, and that's why we're looking for it. I think sometimes it's it's a rule, Medicare's making me, isn't this awful bit that just doesn't help in terms of explaining that this is not us just being difficult, but it really is an opportunity to make sure that we can provide that appropriate level of care because we have the right information. We can't just yell at a nurse's station down the hall or ask for an x-ray or a lab in the house. We need that context.
And I think it's really important to remember as we close out that we're serving our customer, right? We're serving our customer who's our patient. We're serving our customer who's our referral source. And so being able to give that information realistically allows us to serve our clinicians as well, good customer service, because retention of those clinicians is super important. And the more information they have to be informed about where they're going, what they're doing, is going to improve their job satisfaction. So there's a lot of positives. And also, last thought, physicians can receive a fee for care plan oversight and care plan development. And that's something that can be educated to them as well. And that's another way your marketers can educate them that they're receiving the reimbursement that they deserve for all this information that they're providing and partnering in the care of that patient in the home. So thank you so much for listening to our Unfiltered podcast. We always have a lot of fun when we do them, and we really appreciate it. If you have any comments, please leave a comment on the YouTube channel. Let us know how we can improve, maybe some topics that we can cover. And we appreciate all you and all that you all do. Be safe out there.